Welcome to JAT Chat, presented by the Journal of Athletic Training, the official journal of the National Athletic Trainers Association. I'm Dr. Kara Radzak, an assistant professor at the School of Integrated Health Sciences at the University of Nevada, Las Vegas, and your host for today. The purpose of today's event is to provide an open forum for athletic trainers and all other healthcare professionals to ask questions and discuss the recently published Ankle Sprains and Instability special issue from the Journal of Athletic Training. Today, I'm joined by the special edition co-editors, Dr. Jay Hertel, the Joe Geek Professor of Sports Medicine at the University of Virginia, and Dr. Tom Kaminski, the Director of Athletic Training Education at the University of Delaware. I'm also very pleased to be joined by Dr. Phillip Gribble, the Chair of the Department of Athletic Training and Clinical Nutrition at the University of Kentucky. Dr. Gribble is also an associate editor with JAT and contributed greatly to this special issue. In order to make JAT Chat work as smoothly as possible, we ask that you submit questions in the Facebook Live comment section or as a tweet at JAT_NATA using the hashtag JATChat, all one word. At this point, I would like to introduce Drs. Hertel, Kaminski, and Gribble. Thank you all for taking your time to speak with me today.
Thanks for having us.
You bet. Yeah. Thanks for having us. Pleasure to be here.
Thanks, Kara. So my first question is for Jay and Tom. And where did you come up with the name of the editorial, "These are the sprains of our lives"?
Yeah, so this is actually the second special issue on ankle sprains and ankle instability that the Journal of Athletic Training did. So Tom and I co-guest edited an issue back in 2002, and in there the lead editorial was called "As the Ankle Turns." So we kind of wanted to keep with the soap opera theme and draw a connection between the two, because part of it is that I think a lot of athletic trainers and other sports medicine professionals feel like, well, haven't we heard this story before? And that's kind of like the soap opera, like you've seen it before, but they always have to come up with the new twist and the put it into the context of the modern day. So that's kind of what we're shooting for.
I would just add, it's an opportunity for Dr. Hertel's wry sense of humor to come forth as well. So.
That's awesome. When you guys were curating this special edition, what were your goals? What did you want to be included in the special issue?
Well, it's interesting is that, I have a copy here of our issue from 2002. And, I think at that time, Jay and I had gotten together probably at a bar somewhere, and we wrote on a napkin those individuals that we wanted to invite and kind of the topics that we chose back then. And it's interesting to see, how we've come in 17 years since that first special issue in 2002 to where we're at today. And I think that, as Jay and I were discussing how we could move the 2019 version forward, I thought, it was important for us to include some of the younger researchers that are really on the cutting edge of doing some pretty cool stuff in the area of ankle sprain management and ankle instability. But at the same time, we needed to just have some foundational material in there as well. And I think that Jay's lead article about, the paradigm where we started in 2002 and where we're at today in 2019, I thought was a very important part of the 2019 special issue. Jay, your thoughts?
Yeah, I think that there's so much good original research being done in this area that we really wanted to kind of provide a compendium of that and kind of a state of the clinical science for 2019, where ankle sprains and ankle instability research sits. And Philip and Eric Wickstrom and Pat McKean and Ty Hopkins were all kind of involved in the formulation of the articles that we invited.
Mm-hmm. One of the things that I noticed was that there's a lot of these current concept articles, and each one of you actually authored one yourselves. What are the key takeaways from the current concept article that you each authored? Let's talk with, have you start, Tom.
Well, our theme was on prevention of ankle sprains. And, as one of the primary domains of athletic training, I think that, prevention of ankle sprains is first and foremost in our minds. And it was interesting to just kind of go back and look at the historical perspective of ankle sprain prevention through the years. And, traditionally it's been around prophylactic taping and prophylactic bracing.
Mhm.
And those hold true today. I mean, there's a lot of good evidence that supports that, not only to prevent first-time ankle sprains, but the prevention of additional ankle sprains in those that have had ankle sprains is very important through the use of, ankle strapping, ankle taping, ankle bracing. So, I thought that was a key component of it. And the other thing I think that, Jay and Phillip can attest to is that when we set out for these special issues, or we set out for having a position statement put forth, the ultimate end user is the clinician. And so I think that these current concepts really speak to the clinician. And this issue is really just chock full of good information that clinicians can go and start using today.
Thank you. We actually have a question from the audience that relates to what you were talking about, Tom. And the question is, neuromuscular training programs have been recommended for primary and secondary prevention of knee injury. Are there any consistent things that can help with primary and secondary prevention of ankle sprains?
Yeah, and I think that, Patrick McKeon's work and certainly Jay's work and Philip's work in this area really can attest to the fact that those types of neuromuscular training programs in the ankle are quite beneficial. And I think that every clinician needs to have that in their toolbox, not only from an ankle sprain prevention standpoint, but certainly from an ankle injury management standpoint, rehabilitation standpoint as well. And I'll let Philip and Jay chime in as well.
Yeah, it's become the cornerstone of the expansion of what we do for treatment and rehabilitation for ankle sprains, and that's for the acute sprain patient, making sure that as we approach the end stage return to play, that there's neuromuscular rehabilitation really focused on a dynamic balance progression. But what I think we often lose sight of is that there needs to be a maintenance phase as well, because we see so many ankle sprain patients, unfortunately, fall into a path of chronicity and develop chronic ankle instability. And so that's where we continue to evaluate their ongoing deficiencies and still introduce the same kinds of protocols to focus on neuromuscular deficiencies, dynamic balance progressions.
Yeah, I would just echo that end stage ankle sprain rehabilitation should look a lot like prevention programs for ankle and knee injuries, that focusing on dynamic balance and plyometrics and high velocity change of direction movements.
And Jay, your current concept article was kind of discussing this updated model of chronic ankle instability. And you give a really nice, really in-depth view on that spectrum of chronic ankle instability, copers. Where do you feel like this neuromuscular rehabilitation, or all of this aspect of trying to do the return to play rehabilitation, is there possibility of moving somebody from a chronic ankle instability end of the spectrum into a coper? And how do you think we can do that?
Sure. Yeah, I think that there definitely is the ability to move somebody out of the chronic ankle instability classification. And I think, if you look at it, those classifications are largely based on a combination of their ankle sprain history, which you can't do anything about that because it's happened, but then also on their self-reported function, symptoms, and their more objective function as well. And those are things that you can change. And I think that, we've seen from a number of rehabilitation studies have been able to, in a short amount of time, 4 weeks or so of supervised rehabilitation, move people from, at the beginning, they qualified as chronic ankle instability, but by the end of the 4-week intervention, they would no longer have qualified to have started that study. Now, the big issue is, how do you keep people there and continue to maintain their function? And I think that's also a big issue that we see with return to play after acute sprain as well, is that we know that individuals who perform supervised rehabilitation for at least 6 weeks after their initial ankle sprain do much better than people who don't. The problem is not a lot of athletes actually do rehabilitation for 6 weeks after initial sprain, because they are able to get their function up to a level where they can return to sport. And I think that's a big area that we have to continue to look at. How do we get that implementation of the interventions to continue for a longer period of time?
So another audience question is specifically asking about in the secondary school setting. They want to know, how would you recommend advocating for budget to support some external ankle supports?
Well,
Go ahead.
Go ahead, Philip. I was just going to chime in. Jay and one of his former students, Lauren Kramer, actually had a really nice paper a few years back about the cost benefit of ankle bracing and taping. And I think that, in the long run, if schools are willing to put out the money for ankle bracing, it's going to benefit them in the long run, because it's going to prevent ankle sprains from occurring. And I think that, coaches, administrators who control budget lines need to understand that. And I think, ankle bracing should become part of the equipment process. And so I would strongly advocate for that in the secondary school setting.
Yeah, and I think there's great work out of the University of Wisconsin that's shown that repeatedly. More recently, that Tim McGuine was the leader in that work to show across the state, incorporating a lot of secondary schools, multiple sports, that prophylactic bracing and taping was effective at reducing ankle sprain rates. Equally, neuromuscular prevention programs, as we've already touched on, were effective.
Mm-hmm.
The challenge for an athletic trainer is now, and it's convincing the administrations that holds the purse strings to invest the money, and then convincing the other stakeholders, the coaches, the players, the parents, for the time resource, especially on the prevention program side. Tim did a follow-up to some of his work where he went back to some of those schools and showed the evidence to the stakeholders, and then asked, based on the success rates, would you now be willing to invest continuation of resources and time to reduce the injury rates? And there was a very alarmingly high than expected of people that said, well, no, I wouldn't be willing to do it, even though you're showing me that it works. So we've come a long way in the last 10 years. There's more people realizing the importance of this, but we still have a lot more ground to cover to get those resources and time devoted. I think that might trigger some people to think about, if you don't have the financial resources, where if your choice is a bracing prevention approach, then go after the time investment of a neuromuscular prevention program that can be incorporated into the warm-up period or the off-season conditioning period, where you're maybe not really taking up extra time, but you're still getting a lot of benefit.
Mm-hmm.
Thank you. Actually, that leads us to a great follow-up question from the audience of, what are basic exercises or strategies that can be given to an athlete for at home to reduce the risk of repetitive ankle sprains?
Yeah, I think going back to the balance progression, simply standing on one foot, progressing to having your eyes closed. If you're at home, you can just stand on a pillow or a couch cushion to incorporate a more challenging surface. Additional recommendations that have come out of a lot of the work that are in the special issue and the authors have been suggested a series of hopping activities, just hopping front to back, side to side, and then hopping for targets, hopping a little bit farther out of their comfort zone. There's also the dynamic balance tests, such as the Star Excursion balance test, that have been very effective, and that just requires some floor space and a strip of tape. Standing on one foot, reaching with the other foot as far as you can, and returning to your starting point. These are really easy, low-cost exercises that can be done anywhere.
Yeah, if I could just jump in, one thing that I like to tell people to do as a home exercise too for single limb balance is to do that while you brush your teeth. So you kind of build in your own perturbation by moving your arm back and forth or moving your head back and forth with that. And as long as you don't have a lot of sharp edges in your bathroom, you're pretty good with that one.
And I would just add too, I think that it's important from an ownership perspective that, the student athletes, they buy into this, and then, they buy into it in the clinical setting. And then this is some ownership that they can have when they're away from the clinical setting at home, and they can do that because it's so important to their performance that they continue this process. So again, it's changing mindset, as Phillip said. I mean, not everybody's buying into this, and we've got to create this mindset. Student athletes, I think as clinicians, we bought into it, but I think the student athletes need to get that mindset as well.
Tom, you bring up a great point with changing mindset. One of our audience questions is, what do you think is the greatest misconception about ankle sprains, and how do we overcome it?
Yeah, it's interesting. There's a quote, I think, in Prentice's textbook a few years ago that talking about ankle sprains, and it mentioned the fact that most ankle sprains get better, and they're not given, I don't think, as much attention as the ACL injuries or the concussions. But I think there's a little bit of misnomer with that, because we've seen through the years, and those of us who've been researching ankle instability know that a large percentage of those who've had initial ankle sprain go on to develop instability. And so again, I think that from the outset, we need to really, focus that this is not just a simple ankle sprain and it's going to get better. That, people can have long-term complications. And in fact, Tricia Turner had written an editorial in my journal, Athletic Training Sports Healthcare, that, an ankle sprain can lead to cancer. And the point she was trying to make was that, these ankle sprains can lead to long-term disability as an outcome later in life. And, whereas people aren't active anymore, and it really infiltrates, if you will, their lifestyle and what they can do. So that would be my suggestion is, we just can't treat these as such a simple entity. There's a lot going on.
Yeah, I think just to follow up on that Tricia Turner has an article in the special issue about, I believe the title is Lack of I'm going to get the title wrong. Basically, it talks about how among college students, over half of college students who suffered an ankle sprain didn't seek any medical or healthcare professional in the treatment of that. And I think that just gets to that mindset issue of, it's just an ankle sprain. And I think that's something that we have to work not just on public perception on, but I think also within the healthcare professions as well.
Mm-hmm.
So we've got three amazing researchers in this JAT chat today, and somebody wants to know, how did you decide to focus your career on investigating ankle sprains and chronic ankle instability?
Well, when I was deciding to leave a clinical position and go back to school because I wanted to take an academic path. I called one of my mentors from my undergrad and my master's, Kevin Guskowitz, and said, where should I go? And he said, go to Penn State and study with this guy, Jay Hertel. I said, okay. Kevin's a pretty bright guy. And then I got there and Jay said, you're going to study ankles. And I said, okay. And Jay, it's served me pretty well.
Yeah, Jay and I got our start together. Jay was actually a master's student when I was working on my PhD at the University of Virginia. And that's kind of our first foray into the ankle world. I was doing a lot of work with isokinetics, ankle strength. My colleague, Brent Arnold, was a classmate there as well. And, that's where I got my early start. Dave Perrin was our mentor, and he kind of pushed us along in that pathway. And, and Jay and I got together in 2002 actually earlier than 2002. The special issue came out in 2002, but we probably started this in probably 99, 2000 to bring the 2002 special edition to light. So, yeah, I've been doing it a long time.
Yeah, I don't have one of those good stories, about a personal connection. I've actually never sprained either of my ankles, so some epiphany from that. But I think from the clinical side of athletic training, ankle sprains are the most common large joint injury that we see, and surprisingly, they don't all do that well. So once you get started with it, there's still work to be done.
Got the whole research family tree on this JAT chat. So what have you guys seen during your careers that has been meaningful change in both the research and treatment of ankle sprains?
So I think the biggest thing that I've seen change over the past couple of decades is the idea of proprioception and neuromuscular control deficits been present for a long time, but it was really a black box. When you look back into the the late 80s and the 90s, it was like proprioception and neuromuscular control were like this concept. But I think what we really have now is a much better understanding of what's actually happening from a neurophysiological perspective, and that there's different levels of control within the neuromuscular system that are all contributing to this. And one of the things I thought was pretty neat in the special issue is that there were a pair of articles that original research articles that were basically looking at motor cortex activity as it relates to chronic ankle instability, and that's certainly something that in 2002 nobody was thinking about it at all. But when you break down the neuromuscular system, and you kind of realize that you've got your cortex level control, your spinal level control, and then your local level of control in the periphery, and that there's actually dysfunction across that whole spectrum.
Yeah, I was going to say something similar to that. I've been really fascinated and really excited about that avenue of what we're learning about the deficiency and the work that Jay just brought up, the current issue with some of the work by Adam Rosen and Chris Burkle and Ty Hopkins' group out of BYU. And we've been trying to do some of the same things over the last decade and learning just, wow, an injury way far away down at the ankle is creating some things we never thought about as a clinician. I certainly, when I was practicing, never thought about the consideration how the central nervous system is interacting with this. And what we now know a decade later is those unforeseen and really under-addressed issues are likely contributing to the pattern of repetitive injury, repetitive giving way, an adaptation of a movement pattern that ultimately creates people that don't want to move anymore. They don't want to play their sport anymore when they get into their middle-aged years. We have a project that is just up and running here that's funded by the Department of Defense, and we're trying to look at one kind of rehabilitation protocol that starts to address some of those deficiencies sort of a standard of care that doesn't. And what I envision, what I hope, what I think would be kind of cool is maybe a decade from now, clinicians are still doing some of the same rehab for an ankle sprain, some of the foundation work, but now they're doing some things that are brain simultaneously. And I think that's going to be really cool.
Yeah, I couldn't help but to look back in the 2002 issue, and Jay and I actually invited one of the pioneers in the area of ankle instability research, and that was Hans Trapp, who wrote a commentary for us. It was titled Functional Ankle Instability Revisited. And he, along with Dr. Freeman in 1965, these guys were kind of the original pioneers who started to look at ankle instability. I don't know if either one is still alive today, but it's just kind of an interesting perspective and historical perspective to kind of look back at where we were and where we're at today. And I think, as both Phillip and Jay have mentioned, is that we still have a long way to go. I think what we know, certainly from a neuromuscular standpoint, is it has advanced tremendously over the last 20 years, but there's still a lot left to go. And I think that, as Phillip touched on, in 10 years from now, what will we be doing from a clinical rehab perspective that's going to impact? And I think that the newer generation of researchers is really quite impressive in this area of ankle instability and ankle sprain research, which is exciting for us.
I think another element that I've been excited to see about, and is really, I think, summarized collectively the concept papers from the JAT issue. This spans across the papers, from Delahunt, Pat McKeon, and Luke Donovan, some of the work that Tom and Alan Needle and Eamon did. And that is that we need to be thinking about our treatment approaches that starts acutely, but also starts even before that on the prevention side, and then continues on as we try to mitigate the chance of turning into a chronic ankle instability patient. All those authors I just mentioned have concept papers that I think cover this spectrum. And so I think where we're arriving now, and what the clinician needs to take away is rehab doesn't just stop once they return to participation. This concept of a booster shot is becoming more and more popular to think about, so that your athlete, your patient, even though he or she may have started to resume their activity, bring them back in, reevaluate periodically. What are the deficiencies that we may have thought had dispersed, but maybe actually come back? And do they need a booster shot of some of the interventions that we had done previously that we thought they had overcome? And I think that's a new concept that most clinicians, I certainly didn't practice that way, but I think now we need to get that message out that an ankle sprain, very simple injury, very easy to return rapidly, but it's really more of a longer spectrum of care than we used to think about.
That's a great summary kind of your current concept article of that evaluation at the different standpoints of the spectrum. So one of the nice things about this JAT chat format is that it's very interactive. And we had a post on the feed that's not really a question, but an interesting comment that I'd like to have all of you, if you are willing to address. The comment was, secondary school administrators are largely reactive when it comes to injuries. Their focus lies in profit and wins when it comes to athletics. Rarely are these schools willing to be proactive in the prevention of what may not occur or doesn't occur often enough to enter their budget. It's sad but true. Would y'all like to comment on this?
Yeah, I'll start. I think that if you look at secondary school sports participation, to me the number one issue there is making opportunities available for secondary school students. And the notion of player availability as it relates to being able to participate in practice and games because they're healthy, it really should be the number one priority. And everybody wants their best players to be able to play and to not get hurt. But when you look at injury prevention, you don't get to pick which injuries you prevent, which ones you don't. But ultimately, if you can show that, at a team level or at a school level that you are preventing injuries, it's not just that you're preventing injuries, it's that you're actually increasing participation by making players available for their practices and games. So that's just the way that I would look at it, as not preventing things that don't happen, but actually keeping the players that are on the roster available.
That's a good point.
So to kind of wrap it up, I've got one last question for y'all. Other than the special issue, which the viewer who asked this question did make a comment that it was great, the special issue was, they want to know what are other resources that you would recommend for clinicians or for patients regarding ankle sprains and ankle instability.
I would recommend checking out the position statements that the International Ankle Consortium has put forth. All three of us, as well as I think about 10 other folks internationally, have been involved in these position statements. And JAT was involved in co-publishing the first, along with JOSPT and British Journal of Sports Medicine, and then British Journal of Sports Medicine has also helped publish some of the more recent ones as well. I think the most recent position statement we published, our group published, led by Eamon Delahunt, and it's abbreviated the ROAST statement. It really, I think, it becomes the most clinically relevant of the three, and it really takes clinicians through what is the evidence that supports assessing a patient and what their needs are through the rehabilitation spectrum. And we really tried to make that international effort to make it a more clinically relevant resource.
Great.
Yeah,
Okay.
I would second what Phillip has said. In fact, I'm printing it out right now, but our listeners can go and they can get this at the British Journal of Sports Medicine. And it's an infographic that's put out by the British Journal of Sports Medicine on the ROAST guidelines that Phillip talks about. And it really simplifies what every clinician should be doing from the standpoint of initial assessment. It goes over the various areas that we as a collective body, the consortium, talks about are important that clinicians do right away in the attempt of preventing the ankle instability from occurring later on. And this is cutting edge. And this is, I think every clinician should have this simple infographic in their clinical setting and utilizing it on a day-to-day basis. It's very current and it's very relevant.
Yeah, I would just also encourage people to take a look at the NATA position statement on prevention and management of ankle sprains, and that was lead authored by Tom Kaminski. It's about 5 years old now, but it's still very relevant. And I think if anything, some of the things that were recommended in there now, there's more evidence to support it than what was originally there. But I think there's about 36 recommendations in there that should help people in their clinical practice.
Thanks for that plug, Jay. You were co-editor as well, or co-author on that paper as well.
Is there any plans for an update on that position statement anytime soon?
I guess that's up to the pronouncements committee of the NATA to give us the guidance on that. But the fortunate thing for the ankle sprains, as Jay said, that information's still pretty relevant, even though it's 5 years out. Unlike concussions, that stuff is changing every day. So.
Mm-hmm. Great. Well, thank you guys so much for joining me today. We'll be sure to try to send out any links to the resources that y'all talked about to our viewers. And just to let everybody know that if you didn't get a chance to listen to the whole JAT chat, or if you know somebody who would be interested and they didn't get a chance to watch, we will have this posted through JAT's social media in a podcast format as well. Thank you, Dr. Gribble, Dr. Hertel, and Dr. Kaminski for joining me today. Really appreciate your time.
Thank you.
Yeah,
Great.
thanks.
Thanks a
Thanks.
lot.
It was fun. Fun.
Wonderful rest of your day. Bye-bye.